Hello.
Hello.
Hello, sir. Room is open. You can start webinar.
Yeah, it's 8:15. Yeah, just 2 minutes more. We'll wait.
Sure.
Good evening, sir.
Good
Umar here.
evening. Umar, good evening, Umar.
Yes, sir. Okay. എന്താ സാർ വിശേഷം? സാർ ഒരു ക്ഷീണം കാണുന്നല്ലോ, കുറച്ച് ചെറിയ ക്ഷീണം. അതല്ല സാർ, ഒന്ന് കുറച്ച് വർക്ക് കൂടി, കുറച്ചൊന്ന് ഫുഡ് ഒന്ന് കുറഞ്ഞ പോലെ തോന്നുന്നു. I think we should go to some meeting and we'll have a nice time. We all വർഷം പോകുന്നില്ല, ഏനെല്ലാം പോകുന്നവര് next time maybe.
We should go for some annual conference and boost up our morale.
Yes, sir. Okay.
Shall we start or wait for one more minute? We'll wait for one more minute. Just people are joining.
Good evening.
Good evening, sir. Good evening, one sir.
എന്തൊക്കെയുണ്ട് സാറേ വിശേഷം?
ഒന്നുമില്ല സാർ, എങ്ങനെ പോകുന്നു?
Sir, the book is too good, sir. ഞാനത് ഓർഡർ ചെയ്തിട്ടുണ്ട്, കിട്ടിയില്ല. അപ്പൊ ഞാൻ ഐ ഗോട്ട് ഇറ്റ് ഫ്രം ഫ്രം മോഹൻ ലെസ്ലി. സോ അതിന്റെ ക്രക്സ് ഓഫ് ന്യൂറോളജി ആണ്. ഇറ്റ് ഇസ് നോട്ട് ജസ്റ്റ് സൂപ്പർഫിഷ്യൽ, ഇറ്റ്സ് എ ക്രക്സ്, ഇറ്റ്സ് എ ഡീപ്പ്, ഒരു കോൺകോക്ഷൻ മാതിരി അതിന്റെ ഒരു ജിസ്റ്റ് ആണ്. അപ്പോൾ ആക്ച്വലി നല്ലൊരു ബേസ് ലൈൻ നോളജ് ഉണ്ടെങ്കിൽ അത് ആക്സസ് ചെയ്യാൻ പറ്റുള്ളൂ. Oh, it is very nice. So actually I ordered, but I couldn't get it. Maybe I'll get it maybe after some time. Maybe then I'll promote. I'll ask my colleagues and this. So the book is too good, sir.
Thank you. Shall we start? One sir, shall we start?
Yes, sir. You can start.
Okay.
Yeah.
So, good evening to all of you. I think this is the 70th session on the challenging case series. As usual, I will start with the short case first. Is my screen visible?
Yes, sir. It's visible.
Okay. So, the first case is a very ultra short case. It's a case referred as a case of depression. This 47-year-old lady has presented with history of gradually progressive mental decline and slowness in walking for the last 2 years. Past history of acute onset of left lower limb weakness 6 months back, which improved over 2 weeks' time. She was being treated from the psychiatrist for depression. On examination, the high mental function is grossly normal, except for she was slightly mildly apathetic. Cranials are all normal. Motor system, there was generalized akinesia. However, there was no weakness. The DTR were brisk bilaterally, however, planars were flexible. And this is so examination finds for generalized akinesia. Otherwise, not much. Only the history of depression is there, cognitive decline. And there was past history of one episode of hemiparesis from which she improved. That is 6 months back. So this is the MRI of the patient. I'll show the other pictures also. This is one. Only the representative cuts are shown. This being a short case. Okay, that's all. Any thoughts?
VGKC.
Okay. Get hemiparesis from which is improved.
CADASIL.
Yeah, that's correct answer. So look at the MRI, shows the level of hyperintensity here. And the claustral hyperintensity is not seen, the cut is not provided. You can see multiple infarcts in the brain. Present with the psychiatric symptomatology. So this is what test will you do? That it was sent for genetic testing and showed Notch3 gene. So this confirms the diagnosis of CADASIL for this patient. So this is only a very short case, only to show that one should not miss this diagnosis when somebody comes to with so-called depression, because psychiatric manifestations are one of the presentation of CADASIL, apart from the migraine and recurrent strokes. Okay. Any questions? Shall we go to the next Paka case?
Sir, in CADASIL and CADASIL, do you find any difference with the MRI? The recessive and dominant variety?
No. CADASIL is autosomal recessive variety, the other is autosomal dominant variety. I don't know if there is a difference between the two. I have to look up and tell you later.
So CADASIL autosomal dominant recessive.
Yeah, but it autosomal recessive. Like clinical presentation, I don't know. CADASIL is different from CADASIL. That is an entirely different one. Okay, I'll go to the next case. That's this is just 2-3 sentences about CADASIL. It's a monogenic cause of ischemic small vessel disease and stroke. They can present as TIAs and stroke in 80%, cognitive deficits in 50%, migraine with aura 40%, psychiatric disorders in 30%, and epilepsy in 10%. The classical
MRI finding in the classical MRI finding.
The number of hyperintensity, then affection of the external capsule corpus callosum are the classical findings. Skin biopsy may show osmophilic inclusions in the vessel bone, and the confirmatory test is mutation the Notch3 gene. Okay. Now this go to the case, proper case. This case is referred to me by Dr. Shibu Yipen. So can say to him. This is a story of an 88-year-old diabetic man. The main complaint is progressive walking difficulty. The walking difficulty started 5 to 6 months back. It progressed to the extent of requiring support of a walker after 2 months. For the last 1 month, patient required the support of a person in addition to the walker to walk about. The next complaint started as numbness. We started from the neck involving the whole body over a period of 10 days. The numbness improved over a period of 2 months, except in the hands where the paresthesia was persisting. The past history was under treatment from a urologist for perspiration micturition, which has been there for the last 2 years. So this is a story once again. The walking difficulty started 5 to 6 months back. which progressed to requiring a help of a walker in 2 months, which also progressed for the next 1 month. And about one or 2 months later, he noticed numbness which started from the neck involved in the whole body over a period of 10 days. That's what he said. One day he developed numbness from whole body downward, which progressed over a period of 10 days. And over a period of 2 months, the numbness improved with treatment, except in the hands where the paresthesia was persistent. The past history, he was under treatment with urologist for persistence in micturition, which has been there for the last 2 years. Now, this is the examination finding. A tremendous difficulty in walking is short step, is swaying to either side. The tone is normal in both upper limbs. Get weakness of both deltoid, slightly more on the left side. Biceps was also weak. Our triceps was normal bilaterally. Wrist extension was normal bilaterally. Maybe mild weakness on the left side. Our finger extension was weak bilaterally, more on the left side. Hand grip was normal bilateral.
Very good. This is maximum.
Small muscles were weak bilateral. And so also interosseous was also weak bilaterally, more on the left side. Stretching the arm, he has got mild pseudoarthritis in the left hand.
വെള്ളി പൊങ്ങിയിരിക്കണം. അതിന് അടിച്ചു കൊണ്ട് അങ്ങനെ ഇരിക്കണേ. ഒന്നും ചെയ്യരുത്. കൈ പിടിച്ചുകൊണ്ടിരിക്കുക കേട്ടോ.
Coordination. Very mild impairment on the left side. The finger nose is mildly impaired. Tone in the lower limbs are normal.
ചുമ്മാ ഇട്ടാൽ മതി. വീട് എവിടാന്നാ പറഞ്ഞേ?
Hip flexion was weak bilaterally, more on the left side.
ഇവിടെ പിടിച്ചു വെച്ച് നീ പിടിച്ച് നിർത്തണമേ, വിട്ട് കളയരുതേ. പിടിച്ച് നിർത്തിക്കേ. ഇന്നൊരു പൊക്ക് 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 പൊക്ക്.
Also weak on the right side, but slightly more powerful on the right than the left. Knee extension was almost normal bilaterally.
തള്ളിക്കോ, എന്റെ കൈയോട് തള്ളു. അതേപോലെ ഇത് തള്ളണം. എന്റെ കൈയോട് തള്ളു, മുമ്പോട്ട് തള്ളു തള്ളു തള്ളു. വെരി ഗുഡ്.
Nose flexion was normal. Our HL was weak bilaterally.
പിടിച്ചോ പിടിച്ചോ, ഇതും പിടിച്ചേ. ഇനി എന്റെ
Plantar flexion was normal.
പിടിച്ചോ അങ്ങനെ. ഇതും ചവിട്ട് മതി.
Flexoralis longus was weak bilaterally.
അതിനെ പിടിച്ചോ, മടക്കി പിടിച്ചോ, ഇതും പിടിച്ചോ. ഇനി അടുത്തത്
Hip abduction and adduction on lying.
ഞാൻ അടുപ്പിക്കാൻ സമ്മതിക്കരുത്, മനസ്സിലായോ? പിടിച്ചോ, മതി മതി, വിട്ടോ വിട്ടോ, ചേർത്ത് വെച്ചോ.
Again, that's also not.
ഇനി കീഴ്പോട്ട് തള്ളു.
But hip extension was weak bilaterally, more on the left side.
തള്ളി പിടിച്ചോ, പിടിച്ചോ, ഒന്നര പിടിക്ക്.
I can overcome that. That is easy, very much more easy for me to overcome.
തള്ളി പിടിച്ചോ. അച്ഛാ തീർന്ന് ഇപ്പൊ തീരുമേ. തള്ളി പിടിക്കണേ. പിടിച്ചോ, ഈ തള്ളിക്ക് കീഴോട്ട് തള്ളേ.
It is a little more powerful than in the left side. Come to the reflexes. All reflex for absent in them.
ഞാൻ പറയുമ്പോൾ പല്ല് കടിച്ചു പിടിക്കണേ. പല്ല് കടിച്ചു പിടിച്ചേ.
Again with reinforcement. Abdominal reflex for absent.
ഉണ്ടല്ലേ?
Down to the nature, again absent. There is a flicker of movement on the left side.
കൈയൊന്ന് മുറുക്കി പിടിച്ചേ.
That don't reinforce. Just flicker is coming in the cortices. That don't reinforce. Angle jacks for absent.
നേരെ വെച്ചോ.
Plantar was indefinite.
ഉറക്കെ ഉറക്കെ.
The sensation was normal. Is the link counting correctly? One examines the pain, it was normal in the right lower hip,
എല്ലാം ഒരേപോലെയാണല്ലോ.
but it decreased on the left side.
കൂടിയ ഉടൻ പറയണം.
There he is able to feel more
നീ
in
കൂടിയ
left knee,
ഉണ്ടെങ്കിൽ മാത്രമേ പറയാവൂ കേട്ടോ.
but that was not there on the right side.
അവിടെ ഇല്ല,
You can say
കുറവാണ്. ഇനി ഈ കുത്തുന്ന വേദനയും ഇതും വ്യത്യാസമുണ്ടോ?
it
അവിടെ കുറവാണ്.
decreased on the left side compared to right.
ഇതും ഇതും അവിടെ കുറച്ച് പെരുത്തിരിക്കുന്നുണ്ട് അല്ലേ? ഇവിടെ കുഴപ്പമില്ല. ശരി, ഇതൊക്കെ ഒരേപോലെയാണ്. ഇതും ഒരേപോലെ.
Initially, there also is telling it decreased on the left side of the abdomen. When it started taking the pin up again,
എവിടെയെങ്കിലും അതിന് വ്യത്യാസം വന്നാൽ പറയാം.
there he is telling it able to feel the pain. There's a level there. That's is telling it decrease. There he is able to feel well, but there's no difference on the right side. All are same.
ഇവിടെ എല്ലാം ഒരേപോലെ. ശരി, ഒന്നുണ്ടോ?
Able to feel the vibration. Right?
ഞാൻ ചോദിക്കൊണ്ടേ ഇരുന്നുണ്ട്. ഇപ്പൊ ഉണ്ടോ ഇല്ലയോ?
He said yes.
ഉണ്ടെങ്കിൽ മാത്രമേ പറയാവുള്ളേ. ഇപ്പോഴേ
Yes, he said.
ഇപ്പോഴേ
There is present.
ഇപ്പോഴേ
Little finger is not able to say on the left side.
ഇല്ല. ഇപ്പോഴേ
He said yes.
ഓർക്ക് പറയാം, എനിക്ക് കേൾക്കണം. ഉണ്ട്. ഇപ്പോഴേ
He said no on the left side.
ഇപ്പോഴോ
He said again no on the left side.
ഇപ്പോഴോ
It said yes.
ഇപ്പോഴേ
It said no.
ഇപ്പോഴോ
Thumb also now is telling no.
ഇപ്പോഴോ ഇപ്പോഴേ
There he is able to feel.
ഇപ്പോഴോ
Left side, left chin is not able to feel.
ഇപ്പോഴും ഇല്ല. ചെറുതായിട്ട് ഇപ്പം ചെറുതായിട്ട്. ഇപ്പോഴേ
Is a decrease on the left leg. Iliac crest.
ഇപ്പോഴോ ഉണ്ടെങ്കിൽ മാത്രം പറയും, ഇല്ലെങ്കിൽ ഇല്ല. തൊട്ടാ പോരെ പിരിവിരിപ്പ് കൃറന്ന്. ഇപ്പോഴേ
He said no.
ഇപ്പോഴോ
He said yes.
ഇപ്പോഴേ
He said yes.
ഇപ്പോഴും ഉണ്ട്.
The left lower lip and left upper lip is taking.
ഇപ്പോഴേ
The JPS sensation is
അത് ശ്രദ്ധിച്ചോ?
normal in the thumb.
അത് മാറിപ്പോവേ. ഇപ്പം എങ്ങനെയാ? ആ ഇപ്പോഴേ ആ ഇപ്പോഴേ ഇപ്പോഴേ
He said correctly.
ശ്രദ്ധിക്ക് കേട്ടോ, ശ്രദ്ധ വിട്ടു പോവല്ലേ. ഇതിവിടെ കഴിഞ്ഞു. ഇപ്പം എങ്ങനെയാ? ഇപ്പം ഇപ്പം ഇപ്പോഴേ
He said correctly in the right upper lip. Left upper lip, he could not feel anything.
അറിഞ്ഞോണെങ്കിൽ അറിഞ്ഞൂടാ. നൂർത്താണ് അല്ലേ?
Made mistakes.
ഇപ്പോഴേ ഇപ്പോഴേ
Okay, he could not.
ഇതും പറയണേ. ഇപ്പോഴോ ഇപ്പോഴേ
Again, made mistakes.
ഇപ്പോഴോ
Both
ഇപ്പോഴേ
toes he made mistakes.
ഇപ്പോഴേ
Made mistakes.
ഇപ്പോഴോ ഇപ്പോഴേ ഓക്കെ ഇനി അപ്പോൾ കഴിഞ്ഞു കേട്ടോ.
Let's get the gait of the patient. Is positive, is swaying more towards the right side.
ഇനി അച്ഛനെ കാര്യം മുമ്പോട്ട് നടന്ന് നടന്നു കാര്യം തിരിച്ചു വാ. മുമ്പോട്ട് നടന്നേ 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 തിരിച്ചു നടന്നു തിരിഞ്ഞ
Okay. So on examination, failures were normal. The upper limb weakness of both deltoid and biceps. Biceps was normal. Weakness of both finger extensors, small muscles of the hand, more on the left side. Pseudoarthritis the left hand. Lower limb weakness of both hip flexors, left more than the right. Weakness of both hip extensors, again more on the left side. Hip abductors and abductors were normal when examined in lying down position. Dorsiflexus and plantar flexus normal. Weakness of both extensor hallucis longus and flexor hallucis longus. DT are all absent except for flicker of movements of the left cortex on reinforcement. Mandas indefinite. Sensory system impaired pain up to D6 on the left side. Impaired vibration sensation of the left upper limb and left lower limb from C6 downward. JPS is impaired in left upper limb and both lower limb. Right upper limb is normal. Thrombus is positive. Gait, short-stepped gait, could walk only with support. So, where is your localization? If you want any clarification on the signs, I can show the video once again. Otherwise, you can go ahead and think about and then tell me the localization.
The first possibility is a high cervical cord lesion above C6 to the CV junction region, sir, in view of the sensory localization. But some odd points are there, like the weakness of hip extensor, which is more than the abductors, and the gait is somewhat abnormal, sir.
Yeah, not spastic gait. And this reflexes are all absent. And
This can be part of the generalized reflexia. We are not sure, sir.
But on the context of a pyramidal lesion, you expect the reflex to be retained, no absent, it's almost absent. Okay, any other thoughts? Radiculopathy, right?
The odd point is that the radical involvement is patchy actually, and the myelin. Why myelo is also involved is because of the sensory level, especially at the level D6 in the left side, and the posterior column sensory loss, which is very extensive, meaning up to the joint question sense is absent in the upper limb also. Left upper limb.
If it is myelopathy, how to explain the pain and posterior column loss on the same side?
That is lower spinal cord level, sir, before crossing the spinal thalamic tract.
But even then, it should be on the right side, not on the left side.
The high cervical and the medullary junction, sir.
High cervical medullary junction, again, how to explain? Pain loss can never be on the same side of the lesion, wherever you postulate, because the fibers cross at the same level.
Plus radicals, because it cannot, the myelin cannot explain the selective hip flexors and hip extensors, L1, L2, and then the other one is L5 S1. But the other muscles supplied by the same radical is not affected.
Yeah, sometimes it may not be completely affected sometimes. For example, in CADP like thing, we do not
Yes.
fit the pattern of nerve or root pattern. Sometimes patchy involvement can occur. So also see, last time we talked about the ganglion neuronopathy or CASP. You see, last time presented, no? That can it can be really patchy.
Overall, it's what we are seeing is an element syndrome. The sensory level at particular left side, I am not able to explain. That's all. Otherwise, it all fits in a CIDP kind of picture.
Right.
Sir, the clinical picture is more of a pure element syndrome because there is no definite evidence of myelopathy in this case.
Yeah.
And the symptoms are, the signs are patchy. There is a weakness in both upper and lower limbs. That too asymmetrically. All the reflexes are absent. But the odd point is the sensory level on the left side. But there are sensory symptoms in the right lower limb as well. So,
but the right lower limb, it was only confined to the JPS loss of the toes. So that can be due to the diabetic neuropathy, unrelated diabetic neuropathy as well.
Yes, sir. So I would like to postulate something like a CIDP variant, like a CISMP.
Okay.
But the sensory level cannot be explained on the left side. Yes.
Sensory examination is always subjective. So even if you think about myelopathy, same pain and temperature plus pain plus posture column, the same thing can't be explained by any means.
Sir, I have one doubt.
Yeah.
So sensory level on the tongue can be a truncal radiculopathy or a truncal neuropathy.
Yeah, that's a possible. That's what you said. As you said, correct, no? Because in ganglion neuronopathy or CASP or CSMP, the patch may be confined only to the trunk, maybe sparing the lower limbs also, several other parts also. It does not respect at peripheral nerve part. Now, even diabetic also can be explained by that. That can result in loss of pain and temperature on the same side.
Diabetic truncal neuropathy.
Truncal neuropathy plus CADP part. Okay.
So the other possibility would be something like a dural AV fistula, and which would masquerade something like a CADP.
Okay, that's possible, but again, we should get some, if you want to postulate a lesion from C above C6 downward. Sensitive element lesion.
Yes,
Possibility is there.
okay.
Sir, HP was telling that some sensory numbness from the neck to the lower limb, sir, which is odd for a ganglionopathy.
Exactly. Your point is well taken. That's also odd for a, perfectly right. The history part is little odd for a CAD. That cannot occur CAD.
Maybe you have to consider 2 lesions, sir.
Yeah, maybe 2 lesions. Okay, let us see. So the patient was investigated from outside and came with the investigations. So this is NCV done. So what do you find? The angle, the amplitude is low, and the contraction velocity is also decreased. Peroneal, low amplitude. This contraction velocity can go with decreased amplitude. We need not think that there is associated demyelination. But the tibial also amplitude is very low velocity. So also tibial also and decreased velocity. Now let us see the upper limb. Yes, good. There is no decreased amplitude. Good amplitude is the right median. Still, the velocity is decreased. So also in the case of left median also, the amplitude is good, but velocity is decreased. There you can't think of a due to an axonopathy alone. You have to think of a demyelination. Similarly, right ulnar amplitude is good, 6.4. Again, the amplitude, the velocity is decreased. Now look at the sensory potential. The upper limb sensory potentials are all quite normal. But lower limbs, both supraperoneal and sural, are absent. And FA is prolonged in all nerves and absent in the lower limb, obviously because amplitude is so low. But even in the normal, upper limb, the FA latency is prolonged. So, what do you think now?
Hema.
So CADP.
Yes.
Electrophysiology.
The numbness from the neck and the paresthesia of the hands persisting with a normal sensory.
The sensory is affected on the left hand. It's got impaired GPS and vibration of all the fingers on the left side.
Sir, CAN, can we think of a CAN in this case?
But he has got impaired sensation.
Okay.
Impaired sensation, even axonopathy, but demyelinating pattern is there. See the FAs are prolonged.
Okay.
The sensations and the upper limb, both upper limb is normal, no, sir?
No. I think Bindu.
No, electrophysiologically.
Electrophysiologically, also the upper limbs are normal.
Then how to
Cannot
explain
be
the
explained.
weakness of the deltoid and the biceps? The upper limb weakness is there, but the motor is normal.
No, we are not checking the motor conduction, the deltoid and biceps. No, we
The
conducting
fingertips, the small bones are also weak, no, sir?
Yeah, it's weak, but it's not dorsally weak, only mildly weak.
Joint position sense and vibration sense are impaired in the left little finger.
Not
It's a
weak.
normal snap.
Yeah, very good.
So that is how so the sensory this thing is out.
Yeah. So that means that can occur with the lesion proximal to the ganglion.
Yes, sir.
Okay. So what do you think now?
MRI of the cervical also.
What do you think? What is it? Likely diagnosis now?
CADP.
Proximal to the sensory DRG, sir. Lesion proximal to, since also the radicals can be affected, dorsal radicals.
Yeah, so that means it's not only radical, it also proximal and distal to that affected.
So both are there. Proximal and distal to the ganglion, sir.
Yeah, ganglion sub. That is a lot places. Okay.
One doubt, sir.
Yeah.
So clinically, the hip extensor weakness, where do you localize that? So severe weakness of hip extensor is there.
Yeah, hip extensor is weak, hip flexion is also weak. Okay, so that cannot be explained by a radicular involvement. But when we say radicular, we don't, in the case of CADP, it does not fit in with a root pattern. See, the term in the CADP, the term radicular neuropathy is actually false. It's nothing but a neuropathy. Only thing is that in CADP, the myelin, the nerves with thick myelin or large myelinated fibers are affected first. In fact, the nerves supplying the proximal muscles have got a thick myelin. So they are affected first. So it does not respect a lower sucking pattern of neuropathy in CADP. That is why the proximal muscles are affected more than the distal muscles in CADP. Even if in GBS also you find sometimes proximal muscles will be more affected than the distal muscles. It's not fitting with a so-called axonopathy pattern of dying back phenomenon.
So this sensory level at the cervical region, below the neck, can it be due to compression of the cord due to thickened root?
That's also possible. But again, the odd point is the same thing on the same side. Same correlation, think of pain and temperature, pain and the posture on the same side. If you think of CAD, coming to back to the previous question, in CADP we call this radicular neuropathy. But what is there clinically to say radiculopathy? The pattern of weakness is not fitting with the radiculopathy. If you get hip extensor weakness in CADP, you expect the same root is affected, you expect the dorsal to be weak, but they may not be weak. So actually the terminology radicular neuropathy is actually a misnomer and confusing. Only because the pathologically you find radicular involvement, we point the term radicular neuropathy. See, when you get proximal muscle involvement and distal muscle involvement, people tend to call radicular neuropathy. But the pattern does not take the pattern, it is not in the distribution of the root per se. Say, for example, a compressive radiculopathy, the pattern is different. You cut a root, the pattern is different. That's what you get in CAD or AAD. Actually, it's a polyneuropathy. Only thing is that those nerves which are thickly myelinated are affected first. The proximal nerves are thickly myelinated, they are affected first.
Sir,
Okay.
in this case, how can you explain the pseudoathetosis of the upper limbs and the preferential joint positions and vibration on the left side alone?
Exactly. So that's the point. I'll come to that. So the patient came with MRI cervical spine.
So, sir, one more question, sir.
Yeah, please.
Sir, you told there is involvement proximal to the ganglion also.
Correct.
From neprophysiology, what was the point for that, sir?
Because the sensory potential are normal in the left upper limb, left hand. At the same time, he has got impaired vibration joint sense in the left hand.
Okay, from the left side only.
Only in the left hand.
Okay, okay, sir.
Okay.
Sir, there is athetosis of the right upper limb also. No athetosis, but finger incoordination is there in the right upper limb.
No, right upper limb it is not there. Very minimal. If at all, if at all on the left side, it is only on the left side, not on the right side. Right side it is not.
So pseudoathetosis we can get in peripheral nerve lesions also.
Yeah, I can occur evaluation also.
Now, my question is, can this be due to the nucleus, the gracilis and cuneate nucleus isolate? I mean, something like a demyelination in addition to the.
Yes, in the hands as well as hand is concerned, yes. Any lesion anywhere proximal to the ganglion, maybe in the root, maybe in the posterior column can produce the same thing. There also snap will be normal. For example, in the classical MS lesion produces so-called useless hand syndrome, there's a plaque occurring in the posterior column. That produces the hand become useless because of the loss of proprioception. But the snap will be normal. Lesion in the posterior column. Okay, this is the MRI of the cervical spine. This is the axial cut. I'll show go by one. This is second level here. There's a T1. Okay, you want to see the MRI video once again? I will show once again. This is the sagittal cut. This is axial, cervical. Okay. Patient also came with an MRI brain. That is normal. Okay. Now, what do you think now?
Sir, axial cut, there is some compression at the level of 356. So we need to. And the neural foramina also is very, not this, sir, above.
This one?
No, sir. No.
This axial cut.
But there are no signal changes to account.
Sir, we need contrast studies.
Contrast for what? What do you think some mass lesion or something like that?
CSF studies.
No, sir.
Why contrast for?
No, this cannot explain the finding of your
Yeah.
joint.
Yeah, you're right. You're right. So, okay, now I think contrast is not going to give any additional help in this patient. So you want to treat it as CADP. So this patient is already on azathioprine and steroid.
CSF study done
Yes,
in
sir.
this case.
You want CSF?
Repeat conduction, sir. This is conduction is done outside, no, sir?
This conduction is done. No. The conduction is done here only. That is outside conduction is not with the patient.
Sir, there can be
Yes.
Neoplastic
Same condition was
infiltration.
also the same thing, almost the same thing. Yeah, tell me, Bindu.
Sir, you told the patient is already on azathioprine and prednisolone. Patient is not improving. That's why the patient has come. So whether it's a neoplastic infiltration or by contrast study only, we'll be able to know.
Yeah, do you really think that is a possibility here with the peripheral conduction like that? If it's an infiltration that ruled by malignancy, do you expect conduction abnormality, the peripheral demyelinating pattern? You won't get that.
So multiple myeloma or the MGUS can present.
That is a cause of CADP. The second cause, investigate for causes of CADP. First of all, is it CADP alone? That's the question.
Cannot explain, sir.
Yeah, I cannot explain.
Sir,
This probably a peripheral and central demyelination.
So new MRI with the nice cuts.
Okay, let us see.
There's a significant asymmetry is there, sir. That is me.
That's the point. Now, so what's in the case of CADP? What are the points against the peripheral nervous system problem? Let's analyze one by one. One, the pattern of sensory loss. As you all said that thing. And see, the impaired posterior column is confined to the left upper and left lower limb, or on the left side, including the hip, or that also is more left half is affected. That cannot just occur with any kind of CADP, ganglion neuropathy. Totally sparing the right side, involving the left side, is it possible? It's logically incorrect. Theoretically possible, logically incorrect. Second, same pattern of pain loss also. That's also not affecting anywhere on the right side, only confined to the left side. Whether it's difficult to explain by that, when the spinal cord node, but that pattern is not fitting with the peripheral nervous problem. Odd points I'm talking about. Now look at the distribution of the weakness. Here in the upper limb, see, the first thing I noticed was is deltoid and biceps are weak. At the same time, that is a pattern which takes a segmental or a root pattern. Triceps is normal. That's not the pattern of a peripheral nerve pattern or a CADP-like pattern of pain. And the distal muscles, small muscles are affected, that can go with either. So that pattern again tells you that it's not like a CAD peripheral nerve pattern. It's not fitting, more like a root or a segmented movement. And normal triceps power in the presence of significant finger extensor weakness. So what did I do was, I think there's a cord lesion because of the time and the level and the pattern of weakness, and as somebody was pointing out, then history. He was telling that one day had a whole numbness to the below and improved and confined only to the upper limb, hand. And all of you know that in high cervical cord lesion, the numbness is first in the hand and last to go in the hand. So that may be left behind. So all these points favor the patient for cervical cord lesion. So whatever be the conduction abnormality, you have to suspect that thing. And the most important point, also your Bindu and Nimra has also pointed, Feroz has also pointed out, he has got left hand sensory loss. All other areas he's got a peripheral condition is abnormal. But look at the left hand. He has got a posterior column loss, vibration loss, but snap is normal. That can be explained with root alone on that area. What about the other roots are not affected? So that takes you more like again a posterior column. See, the left vibration is lost, the left upper limb up to the hand. The posterior column is also in the hand, and the snap is normal. So you have to think logically that only that part preganglionic is affected is illogical. Less likely. More likely, it is a tract causing his posterior column. But the snap is lost in the lower limb, obviously, it's got a peripheral neuropathy, diabetic peripheral neuropathy as on the left lower limb as well as right lower limb. That is just bilaterally. So that all these lesions point to the fact that there's got a cervical cord lesion. So what do? You cover imaging once again. So we did an imaging with thin cut. Let us see the imaging. I'll stop here for the time being. See, you can see hyperdensity within the cord. I'll put it one by one. And the arrow point hyperdensity. No cut Okay, one. See the hyperintensity here again. The cut. I'll play them. You can see the compression there also, the cord. Just before there is a compression. That one. Cord is compressed hyperintensity within the cord. Now let us see the axial cut. See the hyperintensity within the cord. As the cord is getting compressed. And hyperintensity, you easily make it out that way. Again, can you see the hyperintensity within the cord? Again, you can make it here. And the cord is significant compression of the cord is there. So, now next question is, okay, he has got a cervical cord compression, but what is again is the peripheral, the prolonged FA latency, etc., cannot be explained by a cervical cord compression. And the conduction velocity abnormality with the normal amplitude in certain nerves also cannot be explained by a cervical cord compression. So what will you treat him with? Will you treat him with cervical cord or an associated CADP bar diabetic neuropathy?
Cervical cords.
Cervical cord first.
I would treat as a cervical cord.
Absent reflexes and FA prolongation cannot be explained by simple diabetes also.
Yeah, you can explain. I'll come to that. Why? How can? Because you can have a CADP-like presentation can occur just in diabetic neuropathy. We'll come to that. And moreover, the CADP, classical CADP is also more common in diabetes compared to non-diabetics. There is a school of thought that diabetes can predispose to CADP. Whatever be the school of thought, that can occur in diabetes mellitus. But even without a CADP, even without elevated protein, or even without the classical CADP criteria, demyelinating neuropathy can occur in diabetes.
I will treat the CADP and wait for the code.
Okay. Let's see what you want. So
I will treat with us CADP and I will wait for the code.
The already patient had been receiving treatment for CADP with no improvement.
Sir, could you show the NCS right peroneal tibial? It is normal, no, sir?
Peroneal tibial, I'll go back. I'll show just 1 minute. I will go back and show the NCS. This is the peroneal tibial. That's not normal.
Right peroneal, sir?
Yeah, peroneal on the top, you can see the right peroneal. Amplitude is low and the velocity is also decreased. Decreased.
Sir, tibial, sir. Sorry, sir. Tibial, sir. The reflexes are tibial is normal, but the FJ is prolonged on the right side, no, sir?
Correct. Prolonged. So the question is, can that occur with diabetes? I'll come to that.
Yes, sir.
Yeah, then I'll come to that point. I'll show the literature evidence. So that point. Okay. Now this patient, I just before coming to that point, so patients, I just put the patient cervical collar alone continuously for 2 weeks and bed rest, and actually with 2 weeks rest itself is improved. In the left only porous also improved.
ഈ കാല് കീഴോട്ട് തള്ളേ, തള്ളിക്ക്, ഇത് തള്ളിക്ക്, തള്ളിപ്പിടി, തള്ളു, തള്ളു, പാദം മുകളിലോട്ട് പിടിച്ച്,
That is normally will be good.
പിടിച്ചോ, പിടിച്ചോ.
I did that part.
കാര്യം വലിക്കില്ലേ?
Need to the next.
ഇതോ?
But not much improvement again, but it's much better than before. He was not requiring 2% support for walking. But still his work is possible. They did not improve them. So this is regarding the demyelinating neuropathy in diabetes mellitus. I will just point out to the 11 data, subgroup of patients, and 69.9% had diabetes mellitus, predominantly demyelinating neuropathy. Many of these patients, that is 40%, have conduction block as well. Previous reports of electrophysiological studies in diabetic neuropathy have varied from no conduction block or rare occurrence to the frequent finding of conduction block. These studies, conduction block is defined as that, forget about that part. These various pathophysiological mechanisms. Why demyelination is occurring in proximal lesions due to the nerve ischemia or metabolic derangement of the nerves. That is why these people. The diabetic hematrophy, the pathophysiological mechanism is autoimmune. That is why the response is steroid and IVIG. So something similar thing has been postulated to explain further some CADP-like pattern of neuropathy in diabetes mellitus. Okay, any questions from? Did it clarify the question? The question was, can demyelinating neuropathy can occur in diabetes? They can occur. Some of them can be to the extent that mimicking a CAD.
Even with this lesion, sir, even with this lesion, we cannot explain the same side posterior column and same side pain loss, no?
No, exactly. That cannot be explained by that at all. No, that's a good, even with whatever the available, the radiology picture also you can't explain. With hyperintensity was seen on the left side only, not on the right side. The pain part, we have to think lesion is somewhere the lesion is also occurring the right side as well. Or unrelated.
Or he may be bluffing. He may be bluffing.
Or you may be bluffing, right?
Sir, the weakness in the lower limbs, there is a patchy weakness. How can we explain? Is it
see all the weakness is more on the left side. The same side as the posterior column. That also favors a cord lesion responsible for his disability more than the peripheral nerve involvement problem. Because those flushes are quite good problem. The peripheral nerve is not much affected.
Well, there is a patchy lesion on the right side, not detected in the MRI. That can explain pain loss on the left side.
Yeah, that may be. That also can explain the loss of pain. The important query is that the segmental involvement of the biceps and deltoid. That's one important point. That's when you get that finding, say that's a common site of lesion cervical spondylosis.
So, caudal can be due to part of demyelination itself, cord signal changes.
No, because the compression is occurring only at that level, and same level is the hyperintensity. So that can be taken as not demyelination. That's due to the compression itself.
So the posterior column is not involved in the hyperintensity. No? So the posterior columns are not involved in the cervical cord.
It is involved. That is why he's getting the pseudothetosis with the normal.
In the film, sir, the film is showing more on the lateral side of the cord.
Yeah, but that many times that is showing one abnormality there. That's how the cord is affected. So we found some signal changes there, but that we not expect all the time signal changes to be seen in the posterior cord. So we do not know what cut we are taking, or that may not be seen all the time. Even in subacute combined degeneration, so much severe affect the posterior cord. There won't be MRI may be normal.
But such an intense athertosis, we expect some changes now. So we have seen many cases of cervical myelopathy.
Yeah,
we don't such athetosis.
But we found some hyperintensity here that you can explain that. This is hyperintensity is the cord here. And partly maybe due to the compression itself, due to the hyperintensity, current compression from outside itself. There again, I can show that this sort of a compression occurring here, autocue compression also may be causing that disability of that side.
Sir, one doubt, sir.
Yeah.
In the lower limb, how can we explain that hip extensors and hip flexor weakness, then EHL, FHL weakness?
In FHL, can be explained by your peripheral neuropathy part of it, diabetic neuropathy. There's got impaired posterior column also there. The proximal involvement has to be thought of a demyelinating type of neuropathy, which can be seen in diabetes. See something like an hematrophy like pattern. See, the hematrophy pattern can be of two types. One is an acute presentation with pain on one, asymmetrical pain followed by unilateral weakness of the hip proximal muscles on one limb. That is the classical one. Sometimes you can have subacute chronic variety of diabetic hematrophy, which is bilateral, painless, and proximal. Both will respond to steroid. Respond to steroid will be less for the second variety. That's what I told the pattern. The demyelinating pattern can occur involve the proximal nerves also. That is, this patient did not respond to steroid at certain time.
Sir, was the MRI of the dorsal lumbar done, sir?
MRI of the dorsal lumbar must have been done. I did not take the photo of that. That was normal. Must have been normal. Otherwise, I would have picked up that finding. Shown you the MRI also.
In D10, any lesion that side we have seen, no, sir.
No, but he has got a level. The actual level is posterior column is much above. His hand is also got involved with the posterior column. You mean the pain level on that side? You are right. We got some other lesion on the right side of the dorsal cord, but that was not there. If it had been there, I would have thought that thing. But I don't remember having seen that feeling at that level.
In CADP in diabetic patients, any role for rituximab?
Yeah, so you can treatment is just like any other CAD with steroid and other immunosuppressants.
So, how to describe the gait, sir? What you have to say regarding the gait, sir?
Here he has got, if you look very carefully, he has got a significant posterior muscle weakness. That is, his hip is sagging on either side. So, because of the hip sagging, he's also walking slow and cautiously. It is not a dragging of feet at all, because posterior muscle weakness is causing his disability more in this patient. I will come to that gait again.
അടുത്ത് നിൽക്കണേ ഞാൻ പിടിച്ചു കൊടുക്കുന്നതിനാല് കേട്ടോ
He's sagging on either side.
നടന്ന് അതിന് തിരിച്ചു വാ ചുമട് നടന്നേ 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 തിരിച്ചു നടന്നു തിരിഞ്ഞ
Okay.
Sir, two doubts, sir. Then how to manage this case in the view of diabetes? He's not improving.
No, in fact, even with collar, he improved. No, probably when he was admitted, he went into urosepsis, and then that was going to be antibiotic. We were under treatment urologist. So I asked him to wear collar for 1 month completely, and otherwise you have to offer surgery. But most of this to do surgery is a little difficult. because it's also got superadded peripheral neuropathy part also, or a demyelinating neuropathy part also. So we'll wait for some time and then decide about it. But the question is that the main culprit is cervical cord, and you have to tackle that first. That's why we have different surgery for the time being, and then doing it later on.
He's 88, sir.
Is 80. Yeah, that's also another confounding factor.
So can there be asymmetrical ganglion neuropathy sensory with one affected on the right side, the vibration and position?
Ganglion neuropathy is always asymmetrical, but not this asymmetrical. It may be patchy. But here is only confined to the left side of the body, upper and lower limb, totally sparing the right side at any place. That is odd for a ganglion neuropathy.
But the right side reflexes are absent, no, sir?
Yeah, that may be absent. That may be got a part of an associated with neuropathy. It's called ganglion neuropathy. Only producing severe post-cortical loss confined to one side, only reflex loss on the other side is again odd. You get some sensory finding or something on the other side as well. And as you all know, diabetes alone can produce global areflexia.
Sir, what is the explanation for bladder symptoms, sir?
He had a peripheral problem. In fact, he was a urologist for some urosurgery and obstructive uropathy, and even he undergone a surgery by the urologist in the hospital.
So you showed the upper limb weakness is not suggestive of a cord involvement. Then we should manage the demyelinating partner, sir.
No, in fact, your point is valid. You should treat for demyelinating pattern as well. But he was already given, but not improved. Has already been under treatment without any improvement.
The bladder symptoms can also be due to CADP.
Yeah, it could be that is already has got a reason for that. So whether due to that or part of the cord is coming down.
And the role of a CSF and IVIG, sir, in this type of cases, sir, the diabetes myelopathy.
Your question is valid, but the thing is that we have to decide which is causing his disability. Is the neuropathy causing disability more or the myelopathy causing disability? So overall picture was more like a myelopathy is causing the disability because it's got a predominant the posterior column involvement on the left half of the body. And weakness is that bilaterally again more on the left side. So all point to cord lesion more on the left side. So that and you find hyperintensity in the cord. Obviously, there is superadded neuropathy, but which is more? That's the thing to decide.
So the first MRI and second MRI, the gross difference in findings. What can we explain, sir?
And in fact, the first MRI also there was some compression there. That is why I wanted to. Because
it was there, sir. That is sagittal. It was there.
It was there in sagittal cut.
Yeah.
Axial also.
What casual look one may miss it, but then it was there.
Same Tesla machine.
No, that was done from outside. I don't know which Tesla machine was that. Maybe 1.5 itself. This is the first feeling. In fact, like carefully there is a, but one you have to take meticulously at that area you have to focus. That all depends upon your radiologist's ability. You take the axial cut at the level and you zoom on that level, then take it thick, then only you get a good picture. Okay, shall we go to the next case?
Bladder symptoms, sir. Precipitancy, can it occur in the peripheral prostate disease?
The last doubt, sir, the hip extension weakness more than the hip flexion. We consider again the radicular neuropathy, demyelinating.
Yeah, that's you're right. If in pyramidal lesion, you expect hip flexion is more weak than hip extension. But here, hip flexion is also significantly weak. Not that hip extension. Hip extension is in fact better than hip flexion. Hip flexion, you cannot hold it at all. Hip extension, you can, but I did not examine the prone position, but hip extension is relatively good compared to the hip flexion. That pattern is not against the pyramid.
But while he was standing, he had tendency to fall downwards, like buckling of the knee. He was.
There was no buckling of the knee. He was swaying to either side. Hip was sagging, not buckling. Hip was sagging to either side. But yeah,
Abduction normal power. So by 50 was
down it appeared normal. but on walking it appears sagging. Whether it is to the real weakness or something else, I don't know. Because many things will contribute to his proprioceptive loss and his weakness. Everything will contribute to his disability in walking. The classical spasticity may not be there because associated petroneuropathy is also contributing to the loss of spasticity.
So,
Okay, this is a short case. This is a history of a 58-year-old male. History of episodes of sudden dropping of the head, drooping of the eyelids, and body with collapse to the ground with intact consciousness for the last 6 months. Sometimes it only patient has drooping of the jaw and the neck. And this has been occurring every day from this 1 or 2 attacks. And this is the videos in fact sent by the patient's bystander during the time of attack. Could not open his eyelids, jaw droops, neck posture droops. Start recovering. Now. Okay, what do you think?
myasthenia.
Nice, but episodes occurring, asking what you told me, that's become moderate subsequent till another episode occurring.
Maybe functional.
Partial cataplexy.
Okay, functional cataplexy. Any other thoughts?
He is improving while her wife rubs over the forehead and the face. That's the clue, sir.
That's the clue. You would have improved otherwise also. If somebody has not wiped, we do not know. But sometimes many times it occurs when somebody is not there. Okay. Yeah, Bindu.
Segmental myoclonus.
No, it's not like a myoclonus. Drooping is something that's got hypotonia is occurring, unable to lift up his head, jaw drooping.
In seizure also, is there a chance for seizure?
The patient is perfectly conscious during this time. Okay,
Myasthenia.
Okay, myasthenia is a possibility which you can give, but in between, they're perfectly normal. Myasthenia has to be kept in a possibility like that. But why such attacks occurring? Episodes, attacks.
Is he having liver abnormality, anything, sir?
Okay. What are the questions? What
Liver abnormality?
No liver abnormality. No.
Renal abnormality?
No renal abnormality. Why did you ask renal abnormality? Hypokalemia paralysis. Is it? No.
No, sir. Advanced CKD.
No, CKD can, no, it's not a myoclonus. So
it's like classic drama.
Yeah, this is the what will you ask? So these episodes are precipitated by watching TV or someone calls him unexpectedly.
So this thing, sound matter, startle.
Pardon?
Precipitated by sound, sir.
Yeah.
Reflex.
Watching sound, somebody calls him unexpectedly.
So kind of reflect, just like a reflect
These cataplectic attacks, as Feroz said, it's a typical cataplectic attack. See, this is classically where somebody suddenly calls, some sudden light comes, or what do you call, when he's standing in the bus stand, suddenly some bus comes and trying to catch hold of that, then it develops this cataplectic attack. So I remember one story when the first case I saw was when I was in Kottayam Medical College, when I was doing practice at my home. I called the patient. People were standing there. I called the patient. The patient is not to be seen. Till that time, he was asking, say, why don't you call me? Why don't you call me? And all. When I called him, he is not to be seen. When I called him, suddenly, he's collapsed on the ground. Collapsed on the veranda. Then I went out, what happened to the patient? He was slowly trying to get up from the cataplectic attack. So sudden call, unexpected call, sudden flash of light, some sudden hearing are the things, some sound heard are the things which can precipitate such attacks. Very often we don't see them because the attacks occur not in the hospital, they're occurring when they're at home and all. Only if the video somebody takes, you can see that attack.
But only of the neck muscles, why, sir? Why then not the whole trunk?
Yeah, it can vary from complete body to only partial cataplexy, as far as telling. It may be only drooping, it may be only drooping someday, most of the time, only partial. Jaw only droop. The jaw comes down, droops. You're not able to speak for a moment of time, but conscious. Or sometimes the head droops. Sometimes the body sags. In extreme form, they collapse to the ground. So it may be various, severity can occur. There's also one story behind it. This patient is, in fact, I had seen him about 10 years back. At that time, I did not see the attack. So they told me he is fully conscious, not able to move. And frankly, I told him I thought it is functional at that time. Because I did not see the classical attack. So, in fact, I had put him on fluoxetine. I started him for he is a functional. But he had never had an attack on fluoxetine. Recently, he could not get the medicine. That is why he started getting the attack and came back. So the treatment is also fluoxetine for cataplexy. So put him 20 milligram BD, no further attacks. Other drugs which can be given are you can give promipramine, imipramine can be given, and lefluxin can be given. And classical drugs are fluoxetine and promipramine. You remember some symptomatic cataplexy can occur in Niemann-Pick disease and brainstem. Other conditions occurring in the local lesion brainstem also can produce cataplectic attacks. Any doubts?
Sir, so this is independent of that narcolepsy cataplexy.
It can occur, it can occur along with narcolepsy, cataplexy, and hypnagogic hallucinations. Or it may be independent. Sleep paralysis or not. This Gallino syndrome is a tetrad of narcolepsy, cataplexy, hypnagogic hallucination, and sleep paralysis. But it may be isolated. Narcolepsy can be isolated, cataplexy can be isolated.
Symptomatic, what causes are the causes?
Pardon? Symptomatic causes. It can be described brainstem lesions, brainstem encephalitis can occur with the IgON disease and classically Niemann-Pick disease. Okay.
Okay.
Stop or give one more case.
The one more.
Okay. The story of a 56-year-old man. His complaint started as paresthesia of the right foot 1 month back, which ascended up to the knee over a period of few days, followed by similar paresthesia of the left leg. Okay. In fact, this case really fooled us. He noticed dragging of the right foot for the last 3 weeks and perseverance and maturation for the last 2 weeks. No other complaint. So paresthesia of the right foot, which ascended up to the knee or a period of few days, called bismillah paresthesia of the left leg. Tracking of the right foot for 3 weeks, perseverance 2 weeks. Now this is a story, I think.
ബുദ്ധിമുട്ടെന്ന് പറയാം എന്തൊക്കെ ബുദ്ധിമുട്ടുണ്ടായിരുന്നു?
It is low and peak.
ആദ്യം മുതൽ
കാലിന്റെ പെരുപ്പ് ഇപ്പൊ ഇത്ര സ്ഥലത്ത് വരും. ഇപ്പൊ ആ പെരുപ്പ് വിടം വരും. ഈ കാല് ഇവിടം വരും. ഈ കാലിന്റെ പാവം വരും.
എത്ര നാളായി തുടങ്ങിയിട്ട്?
കുറച്ച് നാളായി, 2 മാസം അത് കുറച്ച് നാളായി, 1 മാസം. പിന്നെ നടുന്നത് പിന്നെ
നടക്കാൻ ബുദ്ധിമുട്ടുണ്ടോ?
നടക്കാൻ അത് ഞാൻ കാണിച്ചതല്ലേ രാവിലെ സാർ ഇങ്ങനെ വലിച്ചു വെച്ച് നടക്കും.
കാല് വലിച്ചു വെച്ചാണ്.
പിന്നെ മൂത്രം തന്നെയാണ്. മൂത്രം പിടിക്കാൻ മുട്ടിക്കഴിഞ്ഞാൽ ഉടൻ തന്നെ മൂത്രം പിടിച്ചെടുത്താൽ മതി.
Okay, go to the examination part. The moments are all normal. Examination. Everything also forward now, but it's slightly more of the right. Flexion was normal.
പാദം മേലോട്ട്, ഈ പാദം മേലോട്ട് മേലോട്ട് മേലോട്ട്, ഈ പാദം മേലോട്ട് എടുത്ത് മേലോട്ട് എടുത്ത്, ഈ പാദം മേലോട്ട് ചവിട്ടിക്ക്, ഇത് ചവിട്ടിക്ക്, കാലിട്ട് അടുപ്പിച്ച് വെച്ച് കാല് അകത്തേക്ക് പിടിക്കണം കേട്ടോ. അടുപ്പിക്കാൻ സമയത്തിന് അകത്ത് പിടിച്ചു. ലൂസാക്കിയിടണേ, ലൂസാക്കിയിട്ട് കൈ നൂർത്തി വെച്ച് ഇച്ചിരി മടക്കിയാൽ അത് മടക്കണ്ട, ഒത്തിരി മടക്കണ്ട.
Bilaterally bridge more on the right side.
ലൂസാക്കിയിട്ട് ബലം പിടിക്കണ്ട കേട്ടോ. പിടിക്കല്ലേ, ലൂസാക്കിയിടണേ. ലൂസാക്കിയിട്ട് ഒരുപോലെയല്ല അറിയാം. ഈ കുത്തുന്നല്ല ഒരുപോലെയല്ല അറിയാം. ഇവിടെ അറിയുന്നില്ല, ഇവിടെ അറിയുന്നുണ്ടല്ലോ, ഇവിടെ അറിയുന്നില്ലല്ലേ, ഇവിടെ അറിയുന്നില്ല.
Also normal.
ഇപ്പോഴും ഇപ്പോഴും
Very big.
ഇപ്പോഴും ഇപ്പോഴും ഇപ്പോഴും
Being only one stimulated with otherwise not. The key to the
സ്പീഡ് കടന്നു. സ്പീഡിൽ
dragging.
തിരിഞ്ഞു നടന്നു. സ്പീഡില്ല തിരിഞ്ഞു നടന്നു.
Okay, motor system tone power normal in both upper limbs. Moderate spasticity right lower limb, mild spasticity in the left lower limb. Power normal. Upper limbs 2+ bilaterally. Lower limb bilaterally brisk, slightly more on the right side. Abdominal plus absent bilaterally. Plantar right upgoing. I did not see it right upgoing here, but anyway, left indefinite. Sensations normal. And impaired JPS on both feet, but he made occasional mistakes. So what do you think the patient is having?
High cortical lesion is the first possibility. So second is the high cervical cord.
Why cortical lesion? It's got both the upper limbs, lower limbs, spasticity. Only on the
High parietal produce spasticity in both lower limbs with urinary involvement and
so if paresthesia of the lower limb and spasticity and precipitancy, where is the first the localization you should keep in mind? Spinal cord.
Yes.
Yeah, either thoracic or cervical, wherever it is. With the absence
It is about T6 myelopathy, about T6.
yeah, about D6 myelopathy, whether it is the upper thoracic or cervical, this is difficult. That should be the localization. Yes, no other headache, nothing to intracranial. So this is a MRI. The dorsal spine normal, cervical spine normal. Actually, the cervical spinal cord, he had OPLL. See this ossification of the posterior nodular ligament. Not much compression, mild compression cervical cord. And then the cord. Not much of a compression. Okay. This is the OPLA part. So, what do you want me to do?
Only mild and the compression.
Compression is only mild. But do you think that you want to intervene now or you alone?
Wait.
Pardon?
Sir,
Yeah, tell me, Bindu.
we can wait.
You can wait, okay. But
Parasagittal നോക്കണ്ട sir.
yeah, parasite നോക്കാം. Okay, but the point again is OPLL is the OPLL is measure for a long period of time. But he is symptomatic for 1 month, and within 1 month he developed bladder problem and all. And that's simply odd, even though not much of mild weakness. So that makes it the bladder development with mild pyramidal weakness. So that makes it a little odd for that. In fact, I did not suspect this lesion. This is what the patient had.
Oh, sorry.
It's got left septal ligament down. So sometimes septal ligament really fools you.
This is unilateral.
the sensory symptoms in the lower limb, sir.
That's correct. That's what exactly. You heard the story, he was telling paralysis the right lower limb, and previously paralysis the left lower limb, then the precipitancy, and examined bilateral brisk reflex. But plantar was happening only on the right side, and dragging was only noticed on the right side. So this In fact, we thought with the since the opinion cannot explain the symptomatology of such short duration. That is why we thought when I went for an MRI of the brain. But first diagnosis was the cervical cord or the upper dorsal cord. This is what we found to our surprise. So always, if you got a doubt, always if you just find a finding in the MRI, always think whether that can explain the disability you are finding in this patient. If you think that cannot explain, you investigate further. That is a lesson. Okay, any questions? Okay, I'll end with one short spotter. Nothing else, no history, nothing. Just me, what do you find?
நெட்டி சொல்லிங்கம்மா அப்படித்தான் சரி போதும் நீ கண்ணு முறுக்கி அடையம்மா முறுக்கி அடையுங்க விடுங்க நல்ல முறுக்கி அடையுங்க விடுங்க சரி நீ சும்மா பதுக்கி அடையுங்க விடுங்க அடையுங்க விடுங்க சரி இனி ஈ சொல்லுங்க ஈ சரி விடுங்கம்மா உன்னோட ஈ சொல்லுங்க சரி விடுங்க இனி கவலை விருப்பிடும்மா விடுங்க உன்னோட விருப்பிடுங்க அப்படித்தான் உன்னோட நல்ல விருப்பிடுங்க விடுங்க உன்னோட நல்ல விருப்பிடுங்கம்மா போதும் போதும்.
Yes, diagnosis.
Reverse markers.
Correct. This is aberrant reinnervation of the seventh nerve. And in fact, from the buccinate, the nerve to the buccinate has gone to the upper eyelid. From the nerve to the upper eyelid, I mean, orbicularis has gone to the lower patient. Aberrant reinnervation is center. Okay, shall we stop? There is no questions. Shall we stop? Any other questions? I will stop. Okay. So, good night, everyone.
Thank you,
Thank you,
sir.
sir. Thank you, thank you, sir.
Thank you, sir. Thank you, sir. Thank you very much, sir.
Thank you all. Good morning, sir. Thank you, Bindu.
Thank you, thank you.
Thank you, sir.